Hi, I'm Jack Cush, Executive Editor for RheumNow, and this is the Week in Review as of April 15th, 2016. This week on RheumNow, a number of interesting items. Last week I attended and lectured at the West Virginia Rheumatology meeting as sponsored by Arthros. One of our keynote speakers there was Ari Fisher from National Jewish Hospital in Denver, and Ari gave a series of lectures, including ones on interstitial lung disease. I put out a number of social feeds and tidbits from his lectures, which included some of the following: that some of the patterns that we often talk about regarding ILD, interstitial lung disease, include things like NSIP, UIP, OP, organizing pneumonia, used to be called BOOP, LIP. These are not diagnoses. Actually, these are patterns of lung disease which actually have clinical associations. Another one was that the most common one that is seen, most common form that is seen, is UIP. That's associated with honeycombing, and this is the most common pattern of lung involvement seen in patients with interstitial lung disease with rheumatoid arthritis. It happens to be the second most common pattern in scleroderma and other connective tissue diseases. Ari talked about nonspecific interstitial pneumonitis, NSIP, and its ground glass appearance being the most common feature associated with scleroderma and other CTDs. Interestingly, patients who have NSIP tend to have better survival than UIP patients. Some consideration came up about when to do high-res CTs in patients who may have ILD, and should these be done in RA patients. Interesting comments on Twitter about does it make sense to do these tests, especially a test that's so high in radiation exposure. You don't want to do them lightly, but there is the problem of 20% of patients have symptoms of ILD in RA, for instance, but maybe 70% have pathologic evidence of ILD on autopsy. When do you find it? How do you find it earlier? Ari offered some suggestions on how to enrich for patients who may have ILD, and those features would include men, those who are smokers, those who are CCP positive, and those, I guess would be the main ones. CCP in itself tends to be an independent risk factor for interstitial lung disease. We do know that NSIP is the leading cause, and ILD is the leading cause of death in scleroderma. A recent news item, or actually journal article, looked at 658 patients with scleroderma and what were the causes of death when they were hospitalized. That included, and they looked for predictive factors. That included those who have a higher BUN, a history of aspiration pneumonia, a low hemoglobin, and non-scleroderma related lung disease. Those are factors that may have predicted increased risk of death in hospitalized patients with scleroderma. Some other interesting tidbits, and a literature article from the GI world talked about perioperative use of methotrexate not being associated with post-operative complications of sepsis when the patients were exposed to methotrexate prior to surgery. So another bit of evidence suggesting that you don't necessarily need to be off of methotrexate or off for a long time to be safer. And then there was a report about the use of colchicine in FMF and averting attacks of familial Mediterranean fever. It compared single dose to BID dosing and saw no difference between the two. And lastly, Sjogren's syndrome, and a meta-analysis of 5 studies showed that rituximab had no effect on outcomes, especially long-term outcomes. On the RheumNow website, we have a number of interesting news articles this past week. Published yesterday, a single report detailing 3 journal articles from the New England Journal of Medicine this week that looked at the utility of doing spinal fusion in patients who had spinal stenosis. The issue there is patients who have symptomatic, problematic spinal stenosis may need to undergo laminectomy and decompression procedures. Is there an advantage to doing a lumbar fusion at the same time? Both studies came away with pretty much the same takeaway. There really is no major benefit, and that this should be reserved for very select situations. There was also an accompanying editorial that was quite instructive and worth reviewing. A very important article this week from Virginia Pasquale's group at the Baylor Research Institute, where she reported on their experience with 150 8 kids who have pediatric lupus. And what they did was they followed these kids serially over time, genomically characterized them, and came up with correlations, molecular correlations between their clinical status, their biopsy status, their serologic status, SLEDAI scores, and that which is seen in their genomic analyses. A very detailed, very dense paper, but the RheumNow review sort of boils this down to a few important facts. Number one, the most common signature that they saw that's associated with disease activity was the plasmablast gene signature. Number two, that while plasmablast and interferon alpha signatures correlate very well with SLEDAI scores, it was shown that it was in fact the myeloid lineage genes and the neutrophil gene expression that was best associated with nephritis and renal outcomes, suggesting that one may get lupus through B-cell activity, interferon activity, plasmablasts, etc., but that the damaging, amplifying, and especially nephritis-inducing damage is maybe best mediated by neutrophil and myeloid activity, and that's something we're probably not addressing very well. Well, in the end, they identified 7 groups of patients who could be genomically identified using the gene signatures for the erythropoiesis, interferon alpha, myeloid lineage, lymphoid lineage, and plasmablast signatures. Using those combinations, they had 7 distinct subsets that could be identified. And imagine if you have identified the right molecular subset, maybe now you could target that. And maybe this is one of the reasons why we've had such difficulty in identifying a great molecular target for lupus. We've had a number of very important biospecific interventions being done in the last few years, rituximab, interferon alpha monoclonal antibodies, really with either no benefit or relatively unimpressive overall outcomes. So I think maybe a smarter approach might be to look at patients and their subsets using this sort of approach. A few more reports included a report from Taiwan on the incidence of TB in their population when they looked at their patients who had rheumatoid arthritis and compared the general population in a 4-to-1 fashion. They had 160,000 patients without RA, and they looked at 42,000 with RA. They showed that RA patients have a 2.7 higher times risk of developing TB, and of course it was even higher in patients who are on TNF inhibitors, adalimumab or infliximab, but not with rituximab. The factors that influence the risk of TB included not just RA, but also comorbidity and the use of prednisone. When they looked at the overall rate of TB in RA patients, they found a rate of 394 cases per 100,000 patient years. That may mean nothing to you, but I'll tell you the US and UK and Canada rate is about 4 per 100,000 patient years. So you can see in an endemic area like Korea and Taiwan, the rates are much higher, and that the use of biologics and the influence of inflammation and comorbidities can be significant in those populations. Lastly, there's obviously a lot of continued buzz about Inflectra and its impact on the market. A nice report written by MedPage Today and published on RheumNow details some of the controversies surrounding the approval of this new biosimilar, with quotes from people like Joan von Felt, who's the ACR president, talking about cost, John Kay talking about interchangeability, which was not sought for by the sponsor, Celltrion, but is still a big issue. Douglas White looked at whether or not physicians are going to go along with it, and whether or not the savings associated with biosimilars will be worth some of the concerns. There's a quote in there from me, some other interesting comments from about the legal perspectives around this. So that can be found and reviewed on RheumNow.com. Have a great weekend, and we'll see you next week on RheumNow. Tune in.